Good afternoon. Everybody's very aware of the various problems that are faced in rural India: preventable illnesses, quality of care, costs, infant mortality, identification and tracking of diseases. The people in this room are probably much more well-versed in these issues than I am, so I'm not going to spend a lot of time getting into the details. One of the big issues that we identified in terms of when we started looking at healthcare and at spatial ideas is that staff salaries account for 65 to 80% of rural health expenditure. But according to national averages, staff absenteeism is at about 43% per annum. Pan-India, 30% of PHCs have less than 60% of the medicines required to administer basic care. 60% are missing at least one medicine critical to providing care. So when this woman is pregnant or ill, what is she supposed to do? Oftentimes she'll forgo care. She'll travel long distances, up to 30 kilometers, to get to a health center. She'll pay exorbitant rates from unregulated private providers who may or may not even have a medical qualification, or she may turn to traditional remedies. The global community is responding by duplicating health services that are already provided by the government and resorting to areas such as telemedicine. At Spatial Ideas, we're working with the government to create tools to make the existing health system more functional and address the issues of rural health delivery to optimize healthcare for the rural poor. Our products ensure medical staff attendance, appropriate levels of medical supplies, timely and cost-effective patient care, mapping of diseases and their spreads, and comprehensive mother-child tracking system. So to do this and understand how to really do it, we started by mapping the problem. We looked at and spoke with patients and understood some of their concerns, the fact that doctors are not available when they go, that doctors may not see them even if they sit for a whole day. We looked at how workflows work within the PHCs and CHCs. So a patient can come in, see the receptionist, have to wait, maybe see the doctor, maybe not see the doctor, then maybe go to the lab or maybe not go to the lab. Then they go to the pharmacist to pick up their prescription only to be told that the medicine's not available and go back and see the doctor, thereby having to wait another half of day. A&Ms who are out in the field working with mother and child health have to travel up to 30 kilometers back to the PHC on a regular basis to deliver their reports, and government doesn't get quality reports. The data operators told us very blatantly that at the end of the month they make up numbers because they didn't feel like putting the data in on a day-by-day basis. Then we asked staff and found out about staff perspective. Government doesn't have the reports that they need to provide medicines in a timely manner to oversee the staff. Medical staff lack basic supplies, they have duplicative work, they have no oversight, no resources for help. And field staff complain about anything from having to bribe a data operator to put data into the system so that they can get paid for their work, to significant paperwork, to the very long distances that they have to travel. With this information, we created a solution that streamlines all of the various government workflows. And I'll provide a demo of this, but we have utilized technologies. We've linked technologies within the health center and then also for the A&Ms who are working with very, very basic level smart tablets that are data enabled. They operate on a 2G network and can operate, and they store data even when they do not have data connectivity. The system has allowed A&Ms to stay in the field instead of traveling back to the PHCs regularly. It ensures accountability and quality at the PHCs because now staff are there, their workflows are streamlined, inventory is maintained, and there's automatic reporting, and the government has real-time accurate reports. I'm going to do a quick demo. How do I escape out of? Oh. Okay. Okay, so this is the dashboard from our health product. Here you can see that right now 17 health posts in Aurangabad are not active of the 23 that are on the system. Of the 6 that are active, the number of patients diagnosed today has been 65. Of 56 beds that are available within those health systems, 2 are occupied. We can now dig into this number and okay, we seem to be having a slight technical difficulty. Anyhow, typically you can drill into the numbers and see who is sitting in that bed and why they're at the hospital that given day. In the last 3 months, 210 children have been vaccinated. This is just the summary report that is what a district... Oh, it's off again. Sorry about this. Move this, please. So drilling into the number, I can see that the 2 hospitals that have beds occupied are Alin and Kanjkeda, and I can see further what are the issues that the patient has been identified with. There are health post reports or trend reports that day by day show what is happening at the health centers. So we see how many patients are coming on average and on a given day. And this is one of the things that is very exciting. You can see exactly how long a patient has waited and how many patients are having extensive waits. Several of the health centers that are in the system now have just recently come on board. Hence why you're seeing many of the above 3-hour wait times. In the pilot model, the health centers that are on there do not have waits over 3 hours any longer. Their waits are all under an hour. You can click in and see who is it that's waiting and what is it that they're waiting for even in these drop-down menus. Then one of the areas that we can see exactly which health issues are coming up at health across the district. And then further, we can go into the patient map and see how these patients are distributed across different health centers. In the patient map, you can pick a particular illness, such as a waterborne illness. And you can see if there's any distribution on where there's waterborne illnesses. So for example, around this health center, 2 of the people in that village had waterborne illness, whereas otherwise it's quite rare in Aurangabad today. So tools like this can enable the government to plan for prevention of different issues. Again, vector-borne illnesses can be shown. When you see clustering of vector-borne, you can predict pollution and so forth. Another area that is included in the system is the MCTS Dashboard. So this information is all coming in through mobile telephony and smartphones that have been given to the A&Ms. They will stay out in the field for a week. So this is showing that 100% of the women who have been included into the A&M system have received their ANC 1 visit, 21% have received their ANC 2 visit, 50% have seen ANC 3 visit. This area shaded here in pink shows pregnancies that are in the critical phase, or the stage at which women may choose to abort if they find out that the child is a female, in areas where female feticide is prevalent. Here on this dashboard, you can see that abortions are down 50% in Aurangabad right now.
Sorry, can you repeat what you said about the child being a female child?
The section that's here in pink is showing the women who are in that stage of pregnancy. And based on that, the A&Ms are advised to take an extra visit during that time to prevent female feticide, because that is the area in which abortion would happen. Then again, we have a map for the MCTS system. So this is showing where where the mothers treated today are, any mothers that are anemic, mothers that are not anemic, vaccinations that are due. You can click in and you can click into any particular area or click out of particular areas to see. So here we can see only the children that have overdue vaccinations. This makes it very easy for the planning commission or the district health officer to plan vaccination camps, and or for the district administrator and district health officer to reach out to the A&Ms and hold them accountable for the work that they're supposed to be doing. Similarly, you can map where are the expected deliveries, so outreach can be done to encourage women to come to the hospital. So that's a quick overview of the dashboards that are provided to the government. And now I'll go back to the presentation. So one of the things that makes our system very effective is that it's extremely easy to use. So the system is extremely easy to use, and I have a tablet that has the A&M dash or program application loaded onto it. Local languages used whenever appropriate. Certain of the government reforms require answers in English, and in those cases, answers are kept in English, but the fields will be kept in either Marathi right now for Aurangabad. We have them in Hindi as well as English, depending on the preference of the A&M. There's time and location reminders for the A&Ms as well as other health practitioners as is appropriate. So when an A&M is in the field, her tablet will remind her anytime she has a visit due in a particular area, as well as if she goes to an area, it will remind her that there's however many additional pregnant women or children that need to be vaccinated in the area. All of the reports are compliant with national standards, and the A&Ms are very happy because it lessens their workload. These are some of the screenshots that show the intuitive use and functionality of the dashboards for the A&Ms, for those of you who do not take a look at the tablet. So it sounds a little too good to be true in some cases, or so we've been told. However, the A&Ms are positively thrilled by the developments. These are two quotes that came, one from an A&M and one from the district collector, that are published in an article that was written on spatial ideas recently. Other results, auxiliary nurse midwives, or A&Ms, report 50% more time to see pregnant women and children because they're not traveling back and forth between the PHC and CHC. Staff absenteeism has reduced to 4%. That's from a 43% national average. And within 2 months of activation, PHCs have 100% of the required medicines that they're supposed to have because district administrators can see exactly what the inventory is on a day-by-day basis. We have several other products for food security, infrastructure, labor management, and cleaner cities. And we build technologies that enable government to provide transparency, accountability, efficiency, and cost savings in the delivery of critical services. Thank you. Yes. We have an application on the tablet. The dashboards can be utilized on either a tablet or a computer.
This is internet-based.
Yes.
So tabs are using 2G or 3G data connectivity. 2G, okay.
They operate on a 2G, but they can also operate without data connectivity. And then when Wi-Fi connectivity or other data connectivity is enabled, they will send the data.
Okay. So because that was my question, if there is no connectivity, how they are using it?
We have tested our systems in some of the most rural areas of Maharashtra without any problems. The data
and UP are two different states.
The data is backed up locally on the tablet until Wi-Fi is available or other data is available. And
Thank
it
you.
can operate without Wi-Fi, or I mean without data service.
That's good. Thank you.
Just on the cost of this entire thing in terms of the costing for the development and the cost of running?
We have been charging 1 lakh per PHC, which includes all of the training and support for all of the dashboards and so forth. The hardware is separate, but we have procured the hardware for Aurangabad. The A&Ms are using tablets that are costing about 6,000 rupees each. They're smart tablets that work in very rugged conditions. And the government has been finding that the report from our district commissioner is that the benefits of the system are outweighing the costs.
And what is the recurring cost? The internet cost or whatever?
I'm not sure what the recurring costs are on the part of the government. The recurring costs in terms of what we are doing is an annual maintenance cost which covers all of the data transmissions and updates into the system as well as maintenance of the system, which is at 15%.
Next, I also have another question. What about insurance of the tabs? Have you tried to tie up with an insurance company against breakage, theft, whatever? Because whenever you give an asset, there's always this concern, how do you make sure that it doesn't get lost, stolen, whatever?
Interestingly, we have found that the A&Ms are really so thrilled about using the tablets that they take extremely good care of them. We haven't worked with the government on getting an insurance policy on them thus far, but we also haven't, in almost a year now, had a single issue of breakage. We actually had an issue where A&Ms who were not yet using the tablets threatened to go on strike if they were not given the tablets. So.
Any other questions from the other side of the room?
7-inch. But the application could even work on a smartphone. We've been utilizing a 7-inch tablet just because it's easier on the eyes. And we've also been looking at the ability of doing things like putting on videos about other aspects of health that could be shown to the women while they're having their services done.
So Android-based or all platform, Windows, Android, iOS?
It's Android right now, but if our team is very solid with technology. If you were to look at the system as a whole, it includes everything from attendance management and inventory management to patient record management and so forth. So it's a very comprehensive system. And putting it onto, we could even put it on an Apple platform if so was requested, but the devices get quite pricey then.
Okay, then over to CG Netswara on the experiences from Chhattisgarh.